Welcome to our channel viewers. This video tutorial is about recent advances in the management of ulcerative colitis. We have designed this video tutorial in a way that we have discussed a real life case and evolved our theoretical discussion around that case. We have covered in detail about the definition, diagnosis, grading and management that includes both medical and surgical. We have tried to cover everything in minute details so that medical student can understand easily about this topic, that is inflammatory bowel disease, ulcerative colitis. I have given a case scenario in my last video tutorial about changing paradigm in pancreatic injury. This was a case of a 25-year-old male who had sustained roadside accident and handlebar injury in the abdomen. Patient has taken treatment in the local hospital and he presented to us after 7 days of injury with persistent pain in the abdomen. His general physical examination was normal, and except for mild tenderness in the epigastrium, the abdominal examination was also normal. I have given this case scenario in my last video tutorial. Viewers can go back to that video for all the details. On evaluation, his amylase level was raised and rest of the workup was normal. The ultrasound abdomen revealed a large belt fan collection measuring 18 into 12.5 cm and seen replacing the entire pancreas. This is the CT scan of that patient, in which there was a large fluid collection in the pancreatic area which was replacing the whole pancreas, and only viable pancreas was present in the head region. I have requested the viewers to give their comments regarding plan of management for this patient, and I have received many replies. And I must say there is not a single solution to single problem, and so we manage this patient conservatively, as the catch point in this patient was patient presented 7 days after trauma, and as patient remained stable during 7 days and there was no other signs clinically or biochemically, hemodynamically patient was stable. So we monitor this patient for 5 days and discharge this patient under close follow-up. I must add at this point that any intervention after 7 days of trauma will be hazardous and may not bring desired outcome. The catch in this patient was that patient was hemodynamically stable and lab parameters were within normal limits. During follow-up, patient was complaining about early satiety and local pressure symptoms and fullness in the abdomen. The cyst size remained stable. We did room-wide cystogenostomy after 12 weeks in this patient, and patient had uneventful recovery. Other option in this patient could have been endoscopic cystogenostomy. One of the viewer has commented that we could manage this patient with the help of pigtail drainage. That would have been required in case this patient developed feature sepsis or if this cyst become infected. Then that line of management was warranted. Otherwise, in asymptomatic, comparatively hemodynamically stable patient, we can go for wait and watch and treat this patient electively with the help of room-wide cystogenostomy, as done in the management of pseudocyst. So coming to the topic of discussion for this video tutorial, that is ulcerative colitis. The ulcerative colitis is defined as a chronic inflammatory condition that causes continuous mucosal inflammation of the colon, usually without granulomas on biopsies. It affects the rectum and to a very extent the colon in a continuous fashion and is characterized by a relapsing and repeating course. So there are few words that we have to catch in this definition, that is continuous, and it starts from the anorectal junction and extend proximally. Another definition is inflammatory bowel disease unclassified, that is IBDU. It is defined as there is no definitive distinction between UC and Crohn disease or other cause of colitis or isolated colitis, but there is no small bowel involvement. So we cannot clearly differentiate between the ulcerative colitis or other cause of colitis or Crohn disease, and it is confined to the large bowel only, then it is called inflammatory bowel disease unclassified. Another term used in IBD is indeterminate colitis. This term is used by pathologists to describe a colectomy specimen with overlapping features of ulcerative colitis and Crohn disease. Another term is remission, and remission in ulcerative colitis is defined as stool frequency less than or equal to 3 per day, and no rectal bleeding, and normal mucosa at endoscopy. We have to remember these terms word by word, and these are the basis of many questions during competitive examinations for post-graduation and super specialty courses. The absence of a histopathological acute inflammatory infiltrate predict quiescent course of the disease. That is, on histopathology, biopsy is taken and there is no inflammatory infiltrate, then it is histologically or pathologically a quiescent course of disease. Coming to the clinical features of ulcerative colitis. Ulcerative colitis affects both males and female equally. There is no gender distinction. The usual presentation is bloody diarrhea, bleeding, tenesmus, urgency, fecal incontinence, and nocturnal defecation. Nocturnal defecation is the symptom which differentiated from irritable bowel syndrome, that we have to remember that IBS and ulcerative colitis can have overlapping features, but in IBS generally there are no nocturnal symptoms. The inflammation characteristically commences in rectum and extends proximally. As I said, we have to remember these words. There is continuous, confluent, and concentric, which are one of the pathognomic features of the ulcerative colitis. There are 3C for UC, that is continuous, confluent, and concentric. Loose stool more than 6 weeks differentiate ulcerative colitis from most of the cases of infectious diarrhea. From that, I mean to say that it is unlikely that any infectious diarrhea will persist for more than 6 weeks. If a patient is presenting with loose stool of more than 6 week duration, then we have to think on the lines of inflammatory bowel disease or ulcerative colitis. There can be simple fistulas in case of ulcerative colitis, but recurrent or complex perineal fistulas should always raise the suspicion of Crohn's disease. So friends, usually we find medical students and postgraduates struggling with the cases of ulcerative colitis. If we remember these words, then it will be easier for us to diagnose and treat a case of inflammatory bowel disease or ulcerative colitis. So this is a case of 25 female who has no known comorbidity with no history of past surgery, and she was apparently well 6 months back. Patient presented to us with history of blood and stool that was 10 to 12 episodes per day, and it came down to 6 to 8 episodes per day gradually. The stool were mixed with blood. She was giving history of tenesmus, loss of appetite was there was no loss of weight, and she also gave undocumented history of low grade fever off and on. Her general physical examination was pulse was 137 per minute. Her BP was on lower side, that is 100/70. She had pallor. The rest of the general physical examination findings, that is ictus, clubbing, cyanosis, colonoikia, lipotendinopathy, and edema, were absent. Her abdominal and systemic examination was within normal limit. Her rectal examination was normal except for the loose stool and occasional staining with the blood. Her basic workup showed HB of 7.6 gram. TLC was on higher side, that is 13,500. The rest of the lab parameters, liver function test, renal function test, and electrolytes were normal. Her screening ultrasound abdomen was normal. So based upon our discussion till now, what is our clinical diagnosis, what are the differential diagnosis in this case, and what is the further workup required for diagnosis of this patient. Please viewers, think over it, write it down, and we'll discuss this case as the theoretical discussion evolves. So stay tuned. The risk factors for ulcerative colitis are family history of inflammatory bowel disease. A meta-analysis showed that appendectomy done for proven appendicitis before adulthood reduces the risk of inflammatory bowel disease by 69%. Appendectomy after onset of ulcerative colitis, the effect, if any, of the course of disease is less clear and subject to the ongoing research. So, appendectomy done for a proven case of appendicitis has a protective effect against the ulcerative colitis. The painkillers, NSAIDs, may exhibit the disease, so we should avoid use of the painkillers in patients of inflammatory bowel disease. The preliminary evidence from open-label studies and double-blind controlled trial showed that selective COX-2 inhibitors are safe and can be used in case of ulcerative colitis patient if required. Vitamin D deficiency, it increases the risk of both ulcerative colitis and Crohn disease, and that is the rationale of using vitamin D supplements in case of inflammatory bowel disease. I have given the relevant reference to all the statements in this video, and most of my this discussion is based upon ECO guidelines, ECO 2017 guidelines, and the reference for which I have given at the end of this video tutorial. Phenotypically, there are basically three types of disease extent in ulcerative colitis. First figure is proctitis, when the inflammation is confined to the rectum only below the rectosquamoid junction. It is in the case of 30 to 60% of patient, and symptoms are rectal bleeding, tenesmus and urgency. The second figure is a case of left sided colitis, when the inflammation extends from the rectum till splenic flexure, and that is a case of 16 to 45% of patient, and the symptoms are proctitis plus diarrhea and abdominal cramping. In 15 to 35% of cases, that is the third figure, is called extensive colitis, when the inflammation extends beyond the splenic flexure, and if it involves the whole large bowel up to the cecum, then it's called pancolitis. The symptoms are left sided colitis plus continuous symptoms, fatigue and fever. As the extent of inflammation increases, the severity of symptom also increases. The proximal extension of proctitis or left sided colitis occur in 20 to 50% of the cases. That means a patient initially having symptom of proctitis or left sided colitis will have the progression of the inflammation to the rest of the colon. The extent of inflammation influences the patient's management and risk of colorectal cancer. Another point is that it is, as I have said, it is continuous, that is always involve the rectum first and extend proximally. So it is not possible that the rectum is normal and patient is having ulcerative colitis of the transverse colon. It always extend from the anorectal junction and will extend proximally. It can be rectum, left side colon or the whole colon. This is Montreal Classification Ulcerative Colitis, and we have to remember this classify the ulcerative colitis based upon disease extent, that is E, and severity, that is S. The disease extent is three types that I have already discussed. That is, it is limbo-rectum, that is E1, or if it is left-sided below the splenic flexure, then it is E2, or if it goes proximal to splenic flexure, then it is E3. The disease severity is S0 to S3, and S0 is clinical remission, that is no symptom, and clinical remission, as I have already said, is defined as stool less than 3 per day and no blood, and there are no causative symptoms. S1 is mild symptom, that is passage of less than or equal to 4 stool per day with or without blood, and absence of any systemic illness and normal inflammatory markers. S2 is moderate, the stool more than 4 per day but with minimal sign of systemic toxicity, and if patient is having systemic toxicity or more than or equal to 6 stool per day with tachycardia or any of these features, that is 6 or more stools with tachycardia, temperature, low hemoglobin or raised ESR, is labeled as severe disease, that is S3. True love and bits, this is another important criteria which is used for identifying severe ulcerative colitis, and it is one of the most validated and most widely used index. So true love and beds is different or moderate only in the case that it is used to identify only the severe ulcerative colitis patient for the diagnosis of severe ulcerative colitis. The indexes for severity are bloody stool frequency more than or equal to 6, temperature more than 37.8, ESR more than 30, tachycardia more than 90, anemia where HB less than 10.5, and only one additional criteria in addition to bloody stool frequency that is more than or equal to 6 per day is labeled as severe attack, and in practice CRP of 30 milligram per liter can be substituted for ESR. So if patient is having tachycardia and his stool frequency is more than or equal to 6, or his ESR is raised, or CRP is raised, or he has low hemoglobin, or he is having raised temperature, then we have to label this patient as a severe ulcerative colitis and manage accordingly. Again, this is quite frequently asked question in most of the competitive examination. And what are the different criteria for true love and beds for ulcerative colitis? Ulcerative colitis and age at the onset. Younger patient, age less than 40, has more aggressive disease and require more immunomodulators and surgical intervention. They are high risk for colorectal cancer and reflects the longer duration of disease. Concomitant primary sclerosing cholangitis, that is extra-intestinal manifestation of the UC, increases the associated risk for colorectal cancer. Up to 50% patients of inflammatory bowel disease experience at least one extra-intestinal manifestation in their life. The reference to all these statements is ECO guidelines, as I said before, the ECO guidelines consensus paper 2016. So how to diagnose the ulcerative colitis? There is no gold standard test for diagnosis of ulcerative colitis. The diagnosis is established by clinical, laboratory, imaging and endoscopic parameters including histopathological examination. We should always rule out an infective cause that is Clostridium difficile infection or cytomegalovirus infection. Repeat endoscopy with histopathological review after an interval may be necessary if there is a diagnostic doubt, and ECO 2017 guidelines recommend that we should always screen for Clostridium difficile infection with every disease flare-up, because that can be added or superadded infection to the pre-existing condition. So what are the laboratory biomarkers for diagnosis of ulcerative colitis? Perinuclear anti-neutrophil cytoplasmic antibodies, that is PNCAs, and anti-Saccharomyces cerevisiae antibody ASCA. The PNCAs are detected in up to 65% of UC and less than 10% of CD. So high PNCAs favor the diagnosis of ulcerative colitis. The routine use of diagnosis and for therapeutic disease is not clinically justified. Only in indeterminate cases or when there is a clinical dilemma, they may be useful. The quantitative determination in clinical differential diagnosis to functional symptom of IBS. So, in case of irritable bowel syndrome, the quantitative determination may be helpful to differentiate, and they will be raised in case of IBD and not in case of IBS. The fecal calprotectin, it is the most sensitive, correlate well with the endoscopic indices. A recent meta-analysis confirmed that low CRP and low calprotectin have a 99% negative predictive value for IBS when considering the diagnosis of IBD. This is important statement, viewers, that if we have a confusion between IBS and IBD, and patient is having low CRP and low calprotectin, then we have to think in favor of IBS, and it is almost 99% predictive of IBS over IBD. So these parameters will be raised, that CRP and calprotectin, in case of inflammation, but not in case of IBS. So coming back to the same case, that we had a lady of 25-year-old female with the history of 6 months history of bloody diarrhea and tachycardia, and she had anemia. Further workup, her HB dropped further from 7.5 to 6.5. Her TLC count became normalized. We have already started on broad spectrum antibiotics including Metrogyl, and platelet was normal. Her rest of the vitamin B12 folate was normal. The iron study showed features of anemia. Serum electrolytes RFT LFT was within normal limit, and her stool Clostridium difficile was negative, and her fecal calprotectin was raised. So, viewers, from this history, what do you think is our diagnosis? What is the severity level of this patient? So, we have reached a clinical diagnosis of ulcerative colitis. As I said, bloody stool tenesmus, more than 6 week duration. There are 6 months in this patient, and assured with cultural symptoms, that was tachycardia, anemia, and raised ESR. So we have a diagnosis of ulcerative colitis in hand, but acute severity is based upon Montreal Classification or two Lobet's criteria that we have already discussed. And the bloody stool more than 6 per day, ESR 60, CRP 100, low HP, they all satisfy the criteria of two Lobet bits. So it will be severe ulcerative colitis, or based upon Montreal classification it will be as 3. So what should be our next investigation? Next investigation, we have to get a histological diagnosis, and we have to rule out the CMV infection based upon DNA PCR, and we have to see the extent of disease. So we plan this patient for sigmoidoscopy. As I said, the rectal sparing in ulcerative colitis is not possible because it is continuous, confluent, concentric manner, always start from the anal bulge. So, normal or patchy inflammation of rectum can be seen if patient is already on treatment like topical corticosteroids or topical mesalamine. Macroscopic and microscopic rectal sparing has been described in untreated children with ulcerative colitis. There are few case reports in the literature where rectal sparing has been noticed, but otherwise it is unusual. And if the rectum is spared, we should not think about diagnosis of ulcerative colitis in adults if he is not taking any treatment. The patchy inflammation of cecum is referred as cecal patch. Again, remember this word, that like in a patient of inflammation extending up to the rectum or up to the splenic flexure, there can be patchy inflammation in the cecum. It is referred as cecal patch, and may be observed in left side colitis. Appendiceal skip lesions, that is involvement of appendix as skip lesion, is reported in up to 75% of patients of ulcerative colitis. So appendiceal skip lesion and cecal patch, these can be non-continuous involvement, and we have to remember these two terms. Again, the appendix involvement up to 75%, as I said, and again we have to remember that appendectomy for proven case of appendicitis before adulthood has got a protective value against the ulcerative colitis. So appendix has a close relation with the ulcerative colitis, and it is an area of ongoing research. Normally, ulcerative colitis will not involve the small bowel, and the involvement of small bowel rules out diagnosis of ulcerative colitis. But the continuous extension of macroscopic or histological inflammation from the cecum into terminal ileum is known, and it is called backwash ileitis. That is the inflammatory reflux of the content in the terminal ileum of 10 to 15 centimeter, and it is observed in up to 20% of patients with extensive colitis. That is, when the colitis extending, it is pancreatic extending up to cecum, then in 20% of cases the terminal ileum may be involved by the inflammation, and rarely ileal erosion may occur without cecal involvement, which challenge the pathogenic theory. This is an exception, and it indicates more severe disease, more refractory course, and increased risk of colon neoplasia. The differential diagnosis for colitis, ulcerative colitis, is Crohn disease. The presence of deep, stellate, linear or serpiginous ulcer, multiple aphthous ulcers, and cobblestoning of the mucosa favors diagnosis of Crohn disease. In particular, skip lesion, ileitis, and perineal disease. These are pointers towards chronic disease. We have to remember that cecal patch and appendix lesions are also known as ulcerative colitis, but that we have to remember. Ischemic colitis is another differential diagnosis, but it is segmental and affects the splenic flexure or descending colon most commonly. There is a sharp transition between the ischemic mucosa and normal mucosa. Endoscopy, they showed petechial hemorrhage, longitudinal ulceration, edema, and bluish-black blebs that favors ischemic colitis. Another differential diagnosis for ulcerative colitis will be radiation proctitis, and prior history of radiation for prostatic or uterine cancer, even if temporarily distant, can help in the diagnosis that it can be case of radiation proctitis. So the differential for case of colitis will be infective, ischemic, Crohn's, or radiation. Coming to the further workup in case of ulcerative colitis patient, the most common endoscopic feature of ulcerative colitis is continuous confluent colonic involvement with clear demarcation of inflammation and rectal involvement. That is, there is an abrupt transition from inflamed and normal areas. Endoscopically, severe ulcerative colitis will be there is mucosal friability, patient having spontaneous bleeding on examination, and deep ulceration. The endoscopic changes characteristically commence at anal bulge. As I said, if the rectum is involved, don't think about the diagnosis. If the rectum is not involved, don't think about the diagnosis of ulcerative colitis or think about other pathology. The demarcation between inflamed and normal areas is usually clear and may occur abruptly within few millimeters. This is another index used for grading the severity of ulcerative colitis, that is ulcerative colitis endoscopic index for severity. It evaluates vascular pattern and the presence of bleeding and ulceration, each within 3 or 4 levels of severity. This is the first validated endoscopic index per severity, UCEIS, that is ulcerative colitis endoscopic index per severity. We have to remember this term. The final ulcerative colitis endoscopic index per severity score is sum of all the 3 or 4 descriptions in the worst affected area of colon visible at scomatoscopy. Original UCEIS attributed a score of 1 for normal, and later on a decision was made to change the numbering of the levels, and normal appearance now corresponds to score of 0, so that the simple sum extends from 0 to 8. So as I said, the ulcerative colitis endoscopic index for severity, these are 3 parameters are evaluated, that is vascular pattern, bleeding, erosion and ulcer. If vascular pattern is normal, that is 0. And if there is patchy obliteration is 1, or if it is totally obliterated, then it's 2. As per the bleeding concerned, none is 0. And if there is a mild mucosal bleeding, then it is 1. If it is luminal bleeding only, 2. And if it is severe luminal bleeding, it is 3. Erosion and ulcers, none is 0. Erosion is 1. Superficial ulcer 2, and deep ulcer is 3. Though UCEIS will range from 0 to 8, and it is validated index of severity based upon endoscopy or coloscopy. So coming back to our case scenario, be it sigmoidoscopy in this patient, at full length colonoscopy was not done for fear of perforation. Full length is not advisable in case of severe colitis, as is the case in this patient of a young lady. So sigmoidoscopy revealed there was loss of vascularity. They have seen up to 15 centimeter. There was granularity. Mucosa was friable, and mucosal bleed was positive. There was superficial ulceration, and biopsy was taken, and PCR was sent for cytomegalovirus infection. So the UCEIS was 2 plus 1 plus 2, 5 oblique 8. Chronic stenosis, another important diagnosis in case of ulcerative colitis, and in long-standing ulcerative colitis, a chronic stricture signals an increased risk of colorectal cancer. Multiple endoscopic biopsies should be taken to exclude carcinoma. CT colonography is advised if structure is not possible with the endoscope. If the dignity of chronic stenosis is unclear, we should perform surgery, that we should resect the stricture, presuming it to be malignant. Patients with chronic stenosis who had no preoperative sign of malignancy on CT or endoscopic biopsy, the carcinoma was diagnosed post-operatively in 7.8% of the patient. So there is a high chance of malignancy in a patient with chronic stenosis with ulcerative colitis, and we should treat this patient aggressively, and if we cannot ascertain diagnosis, we should think about the resection. So what are the histopathology features of ulcerative colitis? For diagnosis, we should take minimum 2 biopsy from at least 5 sites, including rectum and ileum. The basal plasmacytosis is the earliest diagnostic feature with the highest positive predictive value. So remember, basal plasmacytosis is a diagnostic feature. Preserved crypt architecture, absence of transmural inflammatory cell infiltrate do not rule out ulcerative colitis at early stage. The other point is the correct diagnosis is reached in approximately 75% of patients if 3 out of the 4 following on histopathology are met. One is severe crypt architectural distortion, second is severe decreased crypt density, third is an irregular surface, and fourth is heavy diffuse transmural inflammation in the absence of general granulomas. A decreasing gradient of inflammation from distal to proximal favors ulcerative colitis, that is, the rectum is more involved as compared to the descending colon as compared to the transverse colon. So, if there is a decreasing gradient of inflammation from distal to proximal, that favors diagnosis of ulcerative colitis. What are the extra-intestinal manifestations of ulcerative colitis? Anemia is common in UC and found in 21% of all patients, and was also present in our case, which we have discussed. Joint involvement is the second most common extra-intestinal manifestation, 20% of all patients. Osteoporosis should be assessed in all patients with persistently active UC, especially if repeated exposure to corticosteroid or with long disease duration, and that is, as I have already said, that is rationale for supplementing calcium and vitamin D3. Episcleritis usually respond to topical corticosteroids and NSAIDs, and uveitis potentially more severe consequences. So anemia, joint involvement, osteoporosis, episcleritis and uveitis, these are the most common extra-intestinal manifestation, out of which anemia 21% and joint involvement in 20%. Again, the rationale for the basis for these statements is eco guidance, which I have said before also. The hepatobiliary disease is an important consequence of extra-intestinal manifestation in UC, and primary sclerosing cholangitis, that is PSC, is the most important hepatobiliary condition. Stenosis, chronic hepatitis, cirrhosis, and gallstone disease, these are all increased in these patients. PSC, that is primary sclerosing cholangitis, is a major risk factor for both cholangiocarcinoma and colorectal cancer. That is, a patient of UC having primary sclerosing cholangitis, the chances of colorectal cancer are very high as compared to patient who doesn't have hepatobiliary disease in UC. If MRC, that is magnetic resonance cholangiography, is normal and small duct PSC is suspected, we should consider liver biopsy. Ursodeoxycholic acid was shown to improve the level of liver enzymes and to reduce the risk of CRC. So, patient of UC with PSC, that is ulcerative colitis with primary sclerosing cholangitis, we should consider supplementing this patient with ursodeoxycholic acid. But no therapy has been shown to reduce time to liver transplantation, cholangiocarcinoma, or death in these patients. The cumulative incidence of colorectal cancer is 1% at 10 years, 3% at 20 years, and 7% at 30 years. So, as the disease duration increases, the chance of malignancy of colorectal cancer increases. The most consistent risk factor of colorectal cancer is primary sclerosing cholangitis, and absolute risk is up to 31%. So, as I have already said, if a patient with ulcerative colitis and having hepatobiliary manifestation in the form of primary sclerosing cholangitis, there are very high chance of 31%, and we should screen and treat this patient more aggressively. When disease activity is limited to rectum without evidence of previous or concurrent endoscopic and or microscopic inflammation of rectum, a regular surveillance colonoscopy is not necessary. In that case, only squamoscopy is necessary. 22% of patients in the UC with colorectal cancer, the tumor occurred prior to beginning the surveillance colonoscopy. Concurrent primary sclerosing cholangitis, we should do annual surveillance colonoscopy, and irrespective of disease activity, extended duration. Okay. So now, what should be the interval for surveillance colonoscopy in a patient of ulcerative colitis? It is according to the risk. It is annually if patient is high risk, and the criteria for high risk is extensive colitis with severe inflammation, first degree relative with colorectal cancer, age less than 50, intraepithelial neoplasia in any of the previous screening colonic biopsy, or primary sclerosing cholangitis and stenosis. I have already emphasized that any patient ulcerative colitis with stenosis, we have to treat this as a case of malignancy unless proved otherwise. For intermediate risk patient, the colonoscopy recommended every 2 to 3 years, and the criteria for intermediate risk is colitis with mild to moderate inflammation, and it is according to histopathological diagnosis, first degree relative with colorectal cancer, age less than equal to 50 years, and if they are extensive pseudopolyps. Screening colonoscopy is recommended every 4 years if patient is in low risk, and if he doesn't have any of the criteria for high or intermediate risk for the colorectal cancer. So coming back to the case scenario that we have discussed, 25-year-old lady with extensive or severe ulcerative colitis, 6-month history. Her CMV DNA was negative. She doesn't have cytomegalovirus infection, and Clostridium difficile was already ruled out. The histopathological examination revealed chronic active colitis with basal plasmacytosis, loss of architecture, transmural inflammation. She received 4 blood transfusions in the meantime. We have already started her on broad spectrum antibiotic and metrogyl. We have given a trial of intravenous corticosteroids, but that failed, and we gave IV fluids along with sporting measures. After failed trial of corticosteroids, we gave a challenge of tacrolimus, and she responded. Her stool frequency decreased, and HB became stable around 9.8 gram %. So what is the medical management of ulcerative colitis? Detailed discussion is beyond the scope of this video tutorial. Briefly, we have mesalamine, steroids, cyclosporins, thiopurines, and anti-TNF alpha, that is tumor necrosis factor alpha, and vedolizumab. Mesalamine is used for mild to moderate ulcerative colitis for both induction of remission and maintenance. Steroids mainly we use budesonide for mild to moderate ulcerative colitis, and prednisolone for moderate, and IV steroids are used for severe ulcerative colitis as we used in this patient. Cyclosporin, again severe ulcerative colitis after failure of IV steroids, and both steroids and cyclosporin has no role in maintenance. They have only role in remission of the relief. Thiopurines, azathioprine, mercaptopurine, they are used in addition to the other drugs, and they have main role in the maintenance of remission. Infliximab, adalimumab, golimumab, these are used for moderate to severe ulcerative colitis, which is steroid refractory, and after failure of IV steroids. We will cover in detail on the medical management of ulcerative colitis in different video tutorial. For the meantime, we have to remember that these are the drugs mainly used for a patient of ulcerative colitis, that is mesalamine, steroids, cyclosporin, thiopurines, and vedolizumab. Topical mesalamine is the first line therapy for a patient of mild to moderate inflammation. Mesalamine 1 gram suppository OD is preferred initial treatment. Mesalamine foam or enemas are an alternative, or suppository can be given. The suppository deliver the drug more effectively to the rectum that receive higher concentration as compared to the oral routes, and topical mesalamine is more effective than topical steroids. Combine topical mesalamine with oral mesalamine or topical steroid is more effective. The combinations are more effective. The dose response is up to 1 gram of 5-aminosalicylic acid per day, and there is no further therapeutic advantage of increasing the dose above 1 gram dose for topical application, and once daily topical therapy is as effective as divided doses. For extensive colitis, that is left side ulcerative colitis, which is mild to moderate severe, that will be like E2 as per the Montreal Classification, that is extending up to the splenic flexion. We give ASA enema more than equal to 1 gram per day combined with oral mesalamine, that is more than equal to 2.4 gram per day. Topical mesalamine is more effective than topical steroids, that I have already said. Topical therapy achieves higher rectal mucosa 5-aminosalicylic acid concentration than oral. Once daily dosing with mesalamine is as effective as divided doses. Again, it's a repetition of the previous talk. For moderate to severe or mild activity not responding to mesalamine, oral beclomethasone dipropionate 5 mg per day is effective, or budesonide 9 mg per day. For severe left side colitis is an indication for hospital admission. Patient with moderate disease may benefit from higher dose of up to 4.8 gram per day. The ASCENT-2 trial, the median time of cessation of rectal bleeding was 9 days in patients receiving 4.8 gram of 5-ASA per day, 16 days for patients receiving 2.4 gram per day, and 7 days for combination of 4.8 gram and budesonide combination of budesonide and 5-aminosalicylic acid. So the combination has better stop. So the combination has better efficacy in inducing the remission. If symptoms deteriorate, rectal bleeding persists beyond 10 to 14 days, or sustained relief from all symptoms has not been achieved after 40 days, additional therapy with oral systemic steroids should be started. For severe ulcerative colitis, confirm the diagnosis, exclude the enteric infection. We have to rule out Clostridium difficile, as I have already emphasized that for every flare-up or for severe colitis, we have to rule out Clostridium difficile infection and CMV infection. IV corticosteroid remain the mainstay of conventional therapy. Therapeutic alternative for rescue of steroid-refractory disease are cyclosporin, tacrolimus, or infliximab, and they should be considered early on or around day 3. If patient is not responding, like our case which we have discussed in this video, patient failed to respond after 3 days of IV corticosteroids, so we started tacrolimus. High morbidity assured with delayed surgery, so active decision making is required. That means if patient doesn't show improvement, so we have to think about emergency surgery early in the disease process. All patients should receive adequate fluid resuscitation and thromboprophylaxis in the form of low molecular beta heparins. Electrolyte abnormalities and anemia should be corrected. They should receive adequate blood transfusion if required, and they are best cared jointly by gastroenterologist and colorectal surgeon. There are few clinical markers which predict colectomy in patients of severe ulcerative colitis. One is Oxford criteria. If after 2 days of IV corticosteroids, if stool frequency is more than 12 per day, the 55% of patient will require colectomy. If frequency is more than 8 per day, between 3rd to 8th day of IV corticosteroid with CRP more than 45 on day 3, the predicted colectomy rate is 85% during that admission. That means if patient has not responded adequately, or the inflammatory markers are high, the rate of colectomy is high, and these patients will require emergency colectomy up to 85% of cases. So active decision making is warranted, otherwise the mortality rate will rise. Biochemical markers: an ESR more than 75 or a body temperature more than 38 degree on admission. It increases the colectomy rate by 5 to 9 fold. And if there is a lack of response to steroid, as predicted by less than 40% reduction of stool frequency within 5 days, that also there is a high chance that these patients will require colectomy, emergency colectomy. So these are the markers that we have to keep in mind, that after starting the IV corticosteroids or other alternative, if patient not responding or if the inflammatory markers are not coming down, we have to think about the surgery in early course of the disease. If there is a colonic dilatation on X-ray more than 5.5 centimeter or mucosal islands on plain radiograph, 75% of the patient will require colectomy. Presence of ileitis with more than 3 small bowel loops of gaps, colectomy in 73% of cases. Study from Oxford, 13 out of 14 patients with acute severe ulcerative colitis and ulcerative colitis endoscopic index by severity score of more than 7 or 8 needed rescue therapy with infliximab, cyclosporin, colectomy or readmission. Deep ulceration, the most severe endoscopic lesions are located in distal part of colon and can be detected by sigmoidoscopy. So as I said, the inflammation will be more in the rectum. It gradually increases from proximal to distal. That is, inflammation more in the rectum than the sigmoid. It is less in the descending colon and transverse colon. So the severe lesion can be detected by sigmoidoscopy because the most affected part will be the distal part of the rectum or sigmoid. Therefore, complete colonoscopy is not necessary and carries an increased risk of perforation in patients with severe ulcerative colitis. Toxic Magacolon is one of the complication of ulcerative colitis or severe inflammation. That is total or segmental non-obstructive dilatation of colon more than 5.5 centimeter with systemic toxicity. Then we have to think the patient has developed toxic Magacolon. Risk factors for toxic Magacolon are hypokalemia, hypomagnesemia, bowel perforation and antidial therapy. Earlier diagnosis of severe colitis, more intensive medical management and earlier surgery have reduced the incidence and mortality. In addition to IV hydrocortisone, empirical treatment with oral vancomycin should be considered until stool is confirmed negative for Clostridium difficile toxin, that CDTA should be negative. Where colectomy has been inappropriately delayed, mortality up to 50%. So active decision making is required and thus emergency surgery should not be delayed, otherwise mortality up to 50% has been reported in the literature. This is Jalan diagnostic criteria for toxic Magacolon, and again these can be basis of question in competitive examination. So radiographic evidence of colonic dilatation, there is classic finding of more than 5.5 centimeter in transverse colon. If any three of the following are present: fever more than 101.5, tachycardia more than 120, leukocytosis more than 10.5 or anemia, or any one of the following: dehydration, altered mental status, electrolyte abnormality or hypertension, then we should think on the lines of toxic Magacolon. Coming to the surgical management of severe ulcerative colitis, as I have already said, delay in surgery, increased risk of surgical complication and staged proctocolectomy is required. Staged proctocolectomy means in emergency we will do subcolectomy, we will remove whole colon up to a sigmoid and rectal stump is left in situ in the form of distal mucous fistula. For managing the rectal remnant, divide the rectum at the level of promontory, that is at the rectosigmoid junction, or leave the distal part of sigmoid colon in situ to bring out it as a distal mucous fistula. Dividing the middle rectum within the pelvis is not recommended in emergency situation. Mucous fistula, subcutaneous stump or intra-abdominal transaction is all recommended. Transrenal rectal drainage for few days in the form of rectal drainage tube is recommended to prevent flow out of the rectal stump. Bleeding in ulcerative colitis. Severe bleeding occurs with incidence up to 4.5% in patient, and it accounts for 5% of emergency colectomies. Patient with persistent need for transfusion due to therapy refractory bleeding should undergo surgery as a matter of urgency. And indication of surgery with bleeding are massive initial bleeding with circulatory instability or persistent transfusion requirement for more than 4 erythrocyte concentrate per 24 hours. Then we should take these patients for emergency surgery. So coming back to the case that we are discussing in this video, that 25 lady with the severe ulcerative colitis and bleed. So after initial response to tacrolimus, patient again deteriorated and her stool frequency increased to 8 per day and bleeding also increased. Her HP dropped from 9.5 to 5.6 gram per deciliter. So it was a failed medical management of corticosteroid tacrolimus and she had a persistent transfusion requirement. So this lady was taken up after 5 days of medical management. We decided to take her up for the emergency surgery. We did subtotal colectomy, that is, we removed whole colon up to the sigmoid with end-ileostomy and distal mucous fistula through the midline laparatory wound. Cut section of the mucosa from sigmoid to cecum was ulcerated, friable with pseudopolyps. It was a case of pancreatitis, that will be E3 as per the Montreal Classification and S4 as per the severity. This is the cut open specimen of the patient of subtotal colectomy. We have removed the whole colon up to sigmoid. We can see the cecum, ascending colon and transverse colon, descending colon, and we divided just proximal to rectosigmoid junction, that we left the remnant to reach up to the abdominal wound for distal mucous fistula. And we can see this, the whole mucosa, whole colon is studded with pseudopolyps, ulceration, and there are petechial hemorrhages also. So what is the impact of pelvic surgery on fecundity? Female fecundity is reduced after ileal pouch anal stenosis when we take out the rectum, and most likely it isn't affecting the fallopian tubes. One study showed more than 70% reduction of fecundity, whereas other point towards approximately 30%. Laparoscopy IPA is technically feasible and may limit the negative consequences to female. Ileorectal anastomosis carries no associated reduction in fecundity. That means if we don't divide the rectum, we don't dissect in the pelvis, then the fecundity is preserved, as we did in this case. We divided the rectum just above the rectosigmoid junction. In male patient, retrograde ejaculation and erectile dysfunction are the main, still rare, sexuality and fertility related complication. These are the main reference on which my talk is based upon, and viewers can go through these guidelines, there is eco guidelines, and that will be helpful to get more insight into the subject. So for further management of the rectal stump in this patient, be managed with the help of medical management in the form of mesalamine enema and hydrocortisone form enemas, and maintenance therapy with the mesalamine enemas. Patient responded well, and we counsel the patient to complete her family, and after completion of family, patient was taken up for the completion proctocolectomy, and we did ileal pouch anastomosis and coupling tube ileostomy. Patient recovered well. Thanks for watching, viewers. I hope you like the video. Please don't forget to like the video and subscribe to our channel. The channel subscription is free for a lifetime. The knowledge is invaluable. Happy learning. Thank you very much.